On and off we keep seeing patients with rheumatic diseases in childhood. Of this, systemic lupus erythematosus is one of the most common rheumatic disease, especially in an adolescent female. In this video, I have covered the latest guidelines on SLE as given in IAP STG 2022, and I have also added where necessary inputs from Nelson's textbook of Pediatrics, latest edition, where necessary to give a comprehensive coverage for you all. But prior to that, are you someone who wants to stay updated with the latest, who wants to have conceptual clarity, who registers better with illustrations rather than simply reading the boring texts, who wants a succinct summary of most of the topics just before their examinations, and who wants a ready, reliable webinar? Then this channel is certainly the place for you, because here you will be made abreast of the latest clinical recommendations and guidelines in the field of pediatrics, have conceptual clarity about basic and advanced pediatrics, and also learn clinical demonstration skills by virtue of demonstration. What is SLE actually? It is basically a chronic heterogeneous autoimmune disorder which is characterized by the presence of anti-nuclear antibodies and other autoantibodies, but is associated with significant morbidity and sometimes also considerable mortality if it occurs in children. It is typically characterized by multi-system organ involvement. The organ involvement can be sequential or simultaneous, and the organ systems commonly involved are the immunological system, hepatic, renal, CNS, cardiovascular, skin, and musculoskeletal systems, as in any other rheumatic diseases. It is most commonly seen in females, especially of the reproductive age group, rather than males. Toddlers are hardly ever affected, but if SLE occurs in adolescents and in children less than 16 to 18 years of age, it is referred to as pediatric SLE, abbreviated as PSLE, as mentioned in Nelson's textbook of pediatrics, or childhood SLE, abbreviated as CSLE, as mentioned in the IAP STG 2022. What happens actually? There are antigens present in the cytoplasm as well as in the nucleus of the cell, against which antibodies are formed in SLE. On cell disintegration, for example by ultraviolet rays, the antigens become exposed and they interact with antibodies which are formed by the plasma cells. And this leads to the formation of antigen-antibody complexes, and these complexes lead to the activation of the complement system, and especially the activation of this membrane attack complex, and this further leads to disintegration of the cells, cell damage, and further tissue damage. So the cycle continues on and on. So how to diagnose SLE? There is basically an entry criterion. Entry criterion means criterion when you should suspect the patient may have SLE. This entry criterion is the ANA levels in the blood should be more than equal to 1:80 on Hep2 cells or an equivalent positive test ever. So only if the patient is ANA positive, you may think of him. If you suspect clinically the patient has SLE, you should first go for ANA, and if the ANA, quantitative ANA, and if the titer is more than equal to 1:80 on Hep2 cells, then you must apply other criterion and investigate further to confirm your diagnosis of SLE. So if it is absent, do not classify as SLE. If present, only then apply the additive criteria. And these additive criteria are: do not count a criterion if there is more likely explanation than SLE. Occurrence of a criterion on at least one occasion is more than sufficient. SLE classification requires at least one clinical criterion and more than equal to 10 points. This I will explain in the further few scenes, then you will get conceptual clarity about the same. The criteria need not occur simultaneously, and within each domain only the highest weighted criterion is counted towards the total score. So basically there are two domains. Criteria are seen in two domains. First is the clinical domain and second is the immunological domain. So after scoring various parameters in the clinical and in the immunological domains, you calculate a total score, And if the total score is more than equal to 10, along with obviously at least one clinical criterion and the presence of entry criterion, then in that case you label the patient as having SLE. So what are the clinical criteria? Constitutional, that is fever, having a score of 2, musculoskeletal 2, neuropsychiatric symptoms, delirium score 2, psychosis 3 and seizure 5. Now here I will explain to you. Now suppose a patient has 2 neuropsychiatric symptoms, like the patient has seizures also and he has delirium also. So when you look at the neuropsychiatric domain, the score which you will consider will be 5 and not 5 plus 2 or 2. You will consider the highest weighted score. Other clinical criteria are leukopenia 3, thrombocytopenia 4, autoimmune hemolysis 4. Now the other concept here is that if thrombocytopenia is getting explained by another common morbidity, for example the patient has dengue, then you will not consider thrombocytopenia because of SLE, you will consider it more because of dengue. Nephrological criteria are protein more than 0.5 gram in 24 hours, given a score of 4. Renal biopsy class 2/5, that lupus nephritis, a score of 8. Renal biopsy class 3/4, lupus nephritis, then a score of 10. Mucocutaneous criteria include non-scarring alopecia 2, oral ulcers 2, subacute cutaneous lupus 4 and acute cutaneous lupus 6. Serosal criteria are pleural or pericardial effusion, a score of 5, and acute pericarditis, a score of 26. The immunological criteria include antibodies in general, which include antiphospholipid antibodies, a score of 2, and anti-beta-2 glycoprotein antibodies or lupus anticoagulant, a score of 1. Complement proteins, low C3 or low C4, a score of 3, low C3 and low C4, a score of 4. SLE specific antibodies, anti-dsDNA antibodies or anti-Smith antibodies, a score of 6. So the criterion of SLE or the diagnosis of SLE can be confirmed once again if the total score is more than equal to 10 with at least more than equal to 1 clinical criterion and ANA at a titer of more than equal to 1:80 on Hep2 cells to classify the patient as SLE, and this is the entry criterion, which is the first criterion which should be fulfilled before labeling, diagnosing, investigating the person further for lines of diagnosis of SLE. According to severity, SLE can be classified as mild, moderate and severe. Mild SLE has no renal or life-threatening organ system involvement. Moderate SLE has clinically significant but no life-threatening organ system involvement, and severe SLE has major life-threatening organ disease. Basically, we do 3 laboratory investigations in general, which we do in most of the patients, and these are ESR, which is increase in direct proportion to the disease activity but may be falsely elevated in hypergammaglobulinemia. CRP is usually normal even with active disease but is increased in concomitant infection, serositis or arthritis, and ferritin is increased though not as much as in macrophage activation syndrome. Certain specific immunological investigations include ANA, which is detected by indirect immunofluorescence on Hep2 cells, which is the gold standard for detection. It is positive in more than 90% of patients with lupus, and staining patterns reflect antigenic specificity of the antibody. Anti-double-stranded DNA is detected by enzyme immunoassay or immunofluorescence. It has high specificity and is marker for active disease, especially lupus nephritis. Complement estimation is done by nephelometry or enzyme immunoassay. Low levels of C3 and C4 indicate active disease. Extractable nuclear antigens or ENA are detected by immunoblotting or counter immunoelectrophoresis. They give useful information on antigenic specificity of ANA. Antiphospholipid antigens are detected by ELISA for anticardiolipin and anti-beta-2 glycoprotein 1 antibodies. Lupus anticoagulant assay by APTT and dilute Russell Viper's venom time test. It is positive in significant proportion of patients, and heparin and oral anticoagulants may interfere with its detection. Some clinical associations with various antibodies. Anti-double-stranded DNA correlates with disease activity, especially lupus nephritis in some patients. Anti-Smith is specific for diagnosis of SLE. Anti-ribonucleoprotein is associated with increased risk of Raynaud's phenomenon, interstitial lung disease and pulmonary hypertension. So you may monitor the patient accordingly and prognosticate them. Anti-Rho, that is anti-SSA, and anti-La, that is anti-SSAB, are associated with Zika syndrome. They may suggest a diagnosis of Sjogren syndrome. They pose an increased risk of neonatal lupus in offspring, may be associated with cutaneous and pulmonary manifestations of SLE, and may be associated with isolated discoid lupus. Antiphospholipid antibodies, the three most common ones are lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies, pose an increased risk for venous and arterial thrombotic events. Antihistone antibodies may be present in SLE, and they are present in majority with drug-induced lupus. Any idea what is common in the treatment of these diseases? Which diseases? Leukemias, nephrotic syndrome, asthma, JIA, and SLE. If you can decipher the commonality, please do mention in the comment section below, and watch the video till the end if you want to know the answer for true. There are certain principles of treatment of SLE because approach to therapy is individualized for each patient based on the clinical features of that patient. Nevertheless, treatment is unified based on a few guiding principles, and these guiding principles are: first, the treatment has to be done by a multidisciplinary team. Once you assess the patient, once you examine the patient, you have to assess the patient for disease activity and damage index as to which organs are actively involved. This is done by clinical examination as well as by investigations. The therapy is directed to active disease manifestations primarily. One must strive to achieve remission with adequate immunosuppression and maintain it. Therapy for the shortest time period and at the lowest possible doses should be given to prevent the side effects of medications. Maintain normal BP and provide calcium and vitamin D supplementation, especially if the patient is on steroids. Avoid sun exposure and use sunscreens because skin is commonly involved in SLE, as you know, malar rash and other photosensitivity features, and the sunscreens used should preferably have a sun protection factor of more than 30. Prompt recognition and aggressive treatment of flares and infection should be done. One must counsel and educate the parents and child, and transition to adult care is to be done in late adolescence. We assess the disease activity and the damage index by some scores. These are SLE Disease Activity Index or the British Isles Lupus Assessment Group and pediatric version of American College of Rheumatology or Systemic Lupus International Collaborating Clinics Damage Score Index. So this is the photograph of SLE Disease Activity Index. Here I'll show you how to calculate, how to assess. Now, suppose the patient has cranial nerve disorder. You will give the patient as a score of 8, and the cranial nerve disorder is manifested as new onset of sensory or motor neuropathy involving the cranial nerve. So this is how you will assess whether or not the cranial nerve disorder is present. You will assess the disease activity, and the damage index is calculated after scoring the all the systems which are involved. And treatment is given according to the disease severity. Now, for example, if the patient has mild disease, then you will give low dose steroids, hydroxychloroquine and methotrexate, especially for skin and joints. The systems involved in mild disease are generally mild involvement of skin and mucosa, musculoskeletal system, serosa, mild cytopenias and fatigue. Major disease, you have to treat by immunosuppressive drugs, that is, induce remission, maintain remission, give high dose steroids or if required steroid sparing agents, and supportive therapy but obvious. And these include involvement of the central nervous, the cardiac, renal, hepatic systems and severe cytopenias. So What are the common complications which we encounter in patients with SLE? They can be acute or chronic. Acute complications include infections, drug toxicities, renal complications, neuropsychiatric complications, and chronic complications include osteoporosis, malignancy, and atherosclerosis. What is the outcome? Long-term outcome is primarily satisfactory, but early diagnosis and appropriate therapy of intercurrent infections, flares, renal and cardiovascular disease, neurological manifestations, and poor adherence to treatment and adverse effects of medications are the principal deciding factors which shall determine the final outcome of the patient. Common morbidities associated are renal, like hypertension, requirement of regular dialysis and transplantation, CNS, like organic brain syndrome, seizures, psychosis, and neurocognitive dysfunction, cardiovascular, like atherosclerosis, myocardial infarction, cardiomyopathy, and valvular disease, musculoskeletal, like osteopenia, compression fractures, avascular necrosis, immunological, like recurrent or severe infections, functional asplenia, and malignancy, ophthalmological, like cataract, glaucoma, retinal detachment, and blindness, and endocrinological, like diabetes, obesity, growth failure, infertility, and fetal wastage. Counseling and education is a very important aspect of the treatment of SLE. Counseling should be about the chronic nature of illness with flares and remissions, need for prolonged therapy, regular follow-up and compliance, monitoring for side effects of drugs, need for shared care with multidisciplinary team, transition to medical care in late adolescence, and coping strategies for parents and child. So, the answer to this question as to what is common in the treatment of diseases like leukemias, nephrotic syndrome, asthma, GIA, and SLE is that treatment of all these diseases by immunosuppressives, and whenever the treatment is by immunosuppressives, that is, the diseases have an immunological basis, you have two phases of treatment. In the first phase, you induce remission, that is, bring down the activity of the immunological cells to a certain level. This is referred to as induction. And you maintain remission, maintain them the activity of the cells at that particular level, and this is known as maintenance. So you must see that these diseases are of different organ systems, but the common thing is that they all have an immunological basis, and so the treatment is primarily done in two steps. So this was an important concept nugget which I wanted to share with you all personally. So revising our ready reckoner, SLE is a disease with multi-system organ involvement and presence of ANA antibodies. It is associated with considerable morbidity and significant mortality, especially in children and adolescents. The Euler or the ACR 2019 criteria is used for diagnosis. The total score should be more than 10, and there should be at least one clinical criterion along with a positive entry criterion. Not only anti-nuclear antibodies, but rather complete autoantibody panel should be done, because other antibodies have different significances. ANA is the most sensitive, anti-DS DNA is best correlated with disease activity, and anti-Smith antibodies is specific for SLE. Drugs used depend on the severity classification of the disease. Disease activity and damage index scoring should be done, and counseling and education forms a very important and integral aspect of the treatment. Thank you so much. If you did like the video, please do give a thumbs up, and if you do have some concept nuggets, please do share with us, because knowledge increases by sharing. Thank you so much, and please do share.